Well, I like to look good. Okay, I get my hair done once a week. It's no certain day. It's like, well, this morning I really wasn't feeling well. So I said maybe if I get my hair done, I'll feel good. I feel a little better, better than I did.
I brought my organ with me, so I play for the religious services. And I brought my sewing machine so I can make quilts for my brothers and sisters. There's 12 of us, and I'm the oldest, so I'm making a quilt for each one of them.
I don't like being alone. And I like having people around to talk to. My mother used to say, Patty will talk to anybody. And she's right.
What are important to me is the life experiences I've had and the ones I'm going to have.
She has a heart as big as she is. And that's just who she is. It's not anything that she makes up or anything that she tries to show off. She's just someone who loves people. And she loves them by helping and doing whatever she can.
The 4Ms was developed by the John A. Hartford Foundation in partnership with the Institute for Healthcare Improvement, and it's a model of care that all older adult care should be aligned with. So what we notice with our older adults is that best practice guidelines that might apply to a younger person don't necessarily apply to older people, because what matters to them, their goals of care, is different. We guide care by what matters. So the 4Ms includes what matters in the context of that person: medications, mentation, and mobility.
One of the major things that we focus on in the facility that's very important to our residents is quality of life and what matters for them in quality of life. How do we give them those opportunities to engage in their own decision making? I look at a variety of different metrics that help me determine what's important for them, whether it's nutrition, whether it's weight loss, whether it's hydration. I look at some of their activity programming. We look at what makes them feel part of the facility.
A medical provider in the post-acute long-term care setting is actually under the umbrella of many rules and regulations. And when we talk about the 4Ms, it's the overarching model of care.
Oftentimes, I think families step in to take the role because of their power of attorney. And they feel like mom's in a nursing home, I'm in charge. The last thing and probably the most important thing I think for them is to make sure that mom still has decision-making capabilities. If she does, engage her in those. Have mom or dad make those decisions. Everything is taken away from them when they walk through our doors.
So in the post-acute long-term care environment, we have an interdisciplinary team that includes the director of nursing, the nursing home administrator, the therapy department, which includes occupational therapy, physical therapy, speech therapy. We have the nursing staff on the floor who are specialized depending on the floors that they're in. We have social workers on hand, and everybody is working to achieve what matters to the resident. And really, the person that's left out of that team that should be center stage are the family members who are able to speak on behalf of the patient if they no longer can, especially for those people that have dementia. Find out what matters, interview the families, understand that the care of older adults really does drive a different path. And don't necessarily get caught up in every little minutia of the best practice guidelines that might apply to your 35-year-old patient, and instead think about what's best for this person based on their goals of care, their life expectancy, what were their previous advanced directives, what's their current physical function, and are they able to have the quality of life that's important to them based on what matters. When we talk about mentation, we're talking about the 3Ds. So we're talking about depression, delirium, and dementia. So depression is a person's emotions. It can affect how they think. In fact, some people with severe enough depression can bring on a pseudo-dementia. Okay, so the 3Ds tend to overlap. When we talk about dementia, we're talking about a chronic process that will not get better. It is a permanent brain condition, and so we need to understand the timeline of the dementia process. And when we talk about delirium, we really have to understand that that's a medical emergency. So being able to differentiate between those three things is very important in older adult care.
It was like joking, and I was coughing, and I got scared, and the nurse was right there to help me, and it was like they told me to breathe. They told me to breathe, and I was so scared, and I did. They say, breathe, Miss McClendon, breathe in through your nose and blow it out through your mouth. And they were talking to me and taking me back to the floor, and I started to breathe. I could feel the air, and that was so scary, but it's good to have the staff that's there to help you. That's the best thing to do, is to stay calm. Because the more I get scared, my chest to get tight, I'll close up, I'll stop breathing. But the best thing to do is stay calm.
There are people here when I'm feeling down and blue and something's bothering me, I can go and cry on their shoulder, and then I feel better. There are people in therapy that are like that. Katie and Lisa and Ashki. Those three people worked very hard with me and got me in a place where I can function.
Some people come here and think, oh, I don't want to be here. But after they've been here a while and realize that we can do some fun things, that it doesn't have to be a place to come and die, that you can come and you can live your life, you can do what you want to do and when you want to do it, which is nice.
It can be a stressful environment, and so we want to do as much as possible to keep that environment calm and safe.
From a social work perspective, it's so important that they know that they're heard and understood. They're giving up their independence. We offer counseling to them as well, because coming to long-term care is a hard, scary process for them. So meeting with a counselor weekly helps them with adjustment and coping skills and things like that. Our older adults, they're so resilient. I feel like we don't give them enough credit because they're stronger than most people know that they are.
I always liked to dance and go out to the parties and things like that, But that was most of my life, And then I went in the Air Force, and I was still dancing. And they had little shows we put on, and we were modeling clothes and things, and doing little skits and things. And it was fun. It was a lot of fun. I enjoyed it.
Don't like to stay in bed all day. I get up in the morning, and I sometimes don't go back to my room until it's time to go to bed. And I like to go on the field trips, and I like to be able to do some of the things that I would have done if I wasn't injured. I renamed the walking club last year to Walk and Roll. As they walk, we roll.
They have activities here and they have the music. If you go down there any time of the day, you may find her dancing through the hallway. So she loves to dance and she loves music. And she's a talker normally.
When we talk about mobility includes functioning that is part of a person's activities of daily living. So it's what keep people out in their space living their life. So physical function promotes independence, it promotes well-being, it actually facilitates what matters.
We kept falling at our house, and we kept calling the fire department to pick us up off the floor, because my husband, Jerry, he also fell. And so we were picking each other up off the floor, and then the state finally said that we were too dangerous to be able to live alone, so that I had to come to a nursing home.
Therapy plays a huge part in mobility within the facility. They are our experts, our physical therapists, our occupational therapists, even, believe it or not, speech therapy with cognition. They all play a very important role in our residents' mobility throughout the center. Their plan of care that they develop is very individualized. They help us with a framework. What is this patient capable of doing? What should we be looking out for as a nursing staff to keep them safe? How can we best promote their mobility? One of the things that we feel is very hard for a lot of people, especially when they come in and they're on caseload, is they want to sit in the wheelchair right away. We don't want them in that wheelchair. We want them up and moving.
Our role is to find out what matters to them, and we start with that from day one when we go in and do the evaluation. We ask them what they were able to do before, what their home environment is like, if their plan is to go back home. We ask them what their goals are for therapy. So we make sure that we're working on what's important to them.
Keeping a person in the long-term care setting functioning at baseline and not reducing in function is very important. All of our staff encourage people to be up and active and to participate in their own activities, transfer themselves when possible, walk as much as they can, and then we have meaningful activities that incorporate exercise. The plan of care should be modeled after the 4 M's, not include the 4 M's. Then it becomes a master plan at which that you're providing the best care for that person to maximize their physical function, maximize their mentation, make sure that you're achieving the goals that are important to that person, making sure that the medications are helpful and not get in the way of that process.
If anyone watches TV, we're all seeing the latest and greatest drug that's designed to help us. And we add those upon layer, which is a situation polypharmacy. We look at that reduction to see if we can reduce these meds through gradual dose reductions so that people can have the best quality versus being sedated. That's one of the things that I would rather prefer is we do non-pharmacological interventions as opposed to giving a pill. We can take somebody for a walk. We can buy them a soda, buy them a snack, have them fold some laundry. There's a couple of drugs that I absolutely will not use in this facility because I feel that they present a danger to my residents' population. But the pushback is mom has to have it or dad has to have it. So the education component is very important for us so they understand why we would like to do a dosage reduction.
It's not that it's bad medicine, it might just be the wrong medicine or too strong of a medicine. You know, such as certain pain pills for certain people, it might be too much.
It's really important that we monitor medicines and the effects that they have on our residents. Sometimes residents may be sleeping more than usual and eating less, so we always have to do a med review and see if there's a medication that's causing them to sleep more. And then we notify the doctor and they kind of work with us to change that medicine and then ultimately see how that affects them, you know, a couple weeks down when we change the medicine, if they perk up a little bit.
It allows the family and the patient to know that they're in control of their care. They have a sense of autonomy of sorts to say that I'm not just placed here and I don't get to say what I want, what I need.
I feel like she's being well taken care of. And the most important thing is that she's safe.
Some of the barriers that we face are regulations. Sometimes we know that they're geared toward improving quality of care. However, sometimes it's a contradiction with quality of life. Oftentimes I'll see a new regulation that comes out and we're kind of scratching our heads. Where did this come from? What was the spirit of this? Does it promote quality of life? How can we better engage CMS in helping us understand and teach and educate our families? But in the same token, we can help them put good regulation in place that's sustainable and does promote quality of life.
It was taking me some time to get used to we're here, where I'm at, So much was going on at once. You know how that happens, You hurt yourself, and then you're dealing with this, and you say, okay, now who's gonna pay for this? And I gotta get well.
My doctor that I had, he always told me, he said, Dorothy, don't let it beat you. I think about that because I do want to live as long as God wants me here. And I got 3 children and 3 grandchildren, and I think about them all the time. Yeah.
I just feel like there's an open door. I feel like they're here for a purpose, and you can see what the purpose is by the care that's not only given to the residents, but to the facility. And when you see that the facility is well taken care of and that they do care about not only what's going on inside of rooms, but the way it's presented as a whole, it brings such joy.
People stop me in the hall and talk to me now that I make a point to introduce myself to pretty much everybody I meet. And they will stop me in the hall. They got something they want to talk about or a problem they're having, and I seem to be the information line sometimes.
I've made a life here, and I'm happy here.
It's important for them to feel like somebody that's doing something still, they just came from having a job, having a house, taking care of people, and giving them a purpose. That's something that matters to a lot of our residents.
It is more an emphasis on what is important to the resident. In the beginning it was the same old stuff. It was bingo, birthday parties, little things. But as the time has gone by, we've learned to find out what the resident likes, what is important and matters to them.
After seeing the film today, I hope that you would understand that the 4 M's are very important to incorporate into the plan of care. Most importantly, take the time to really interview patients and understand what matters in their words and why, so that you can be a partner and collaborate in the care that they are receiving.